Today we'll see about how can we read chest X-ray. My name is Dr. Kababe Bakkala. I am from Madolabu University Goba Referral Hospitals. So the objective of this video presentation is to assist the medical student on basic skills on how we read chest X-ray. So these are the contents. For chest X-ray reading, first we need to have a full identification of our patient, the age, sex, date of X-ray taken, the chart or medical registration number, and the diagnosis or possible complaints of the patient. So these are very important for reading of chest X-rays. The other important, before you look at details on chest X-ray reading, you should identify which one is the right side, which one is the left side. The other is also to know whether the chest X-rays has rotation or well centered. The other important is quality of the X-ray, whether it is good penetration, over penetration, or poor penetration, because this will make chest X-ray reading difficult to diagnose certain diseases. The other is to know whether the X-ray is inspiratory or expiratory film. For most of the chest pathologies, mainly the lung, we need inspiratory film. The other important parameter is whether the chest X-ray is taken in a erect or in supine film. These are also important, mainly on description of mediastinal widening, or mainly on the upper mediastinum. So when we see one by one, one is one of the important chest X-ray parameter before you are reading in detail is whether there is a rotation or not. To know whether there is a rotation or not, we need to identify the medial border of the clavicle on both sides and their distance from the midline, or simply the spinous process. So almost in this X-ray is almost the distance between the two endomedial clavicle up to the spinous process is almost nearly equal. So we can say this chest X-ray is slightly well centered, but there are some rotation on this side because the distance from midline to here is somewhat wider than the distance from here to here. Simply y is greater than x. So these are important because it will make one of the hilum more marked. So if we see this chest X-ray, the medial border of the clavicle is here on this X-ray, and here on this clavicle, and here on this clavicle. So almost this one is very far from midline. So there are some rotation making the hilar more marked on one side. The other important is on looking on expiratory and inspiratory. Expiratory and inspiratory. For most chest X-ray, usually we need an inspiratory X-ray. How can we know that? Usually there are anterior and posterior ribs. So the posterior ribs, like 10, 11 ribs, are when visible clearly on chest X-ray. That's almost an inspiratory field. Or if the 6th anterior rib crosses the dome of the diaphragm, at least 6 rib crosses the dome of the diaphragm, that film is usually an inspiratory film. So to describe which one is anterior and posterior X-ray ribs, these are the posterior ribs. These are the posterior ribs. These are the anterior ribs. These are the anterior ribs. These are the anterior ribs. So you count. This is the first rib, second rib, third rib. Sorry, this is the first rib, second rib, third, fourth, fifth, sixth. On this film, almost the 6th is the anterior rib crossing the dome of the diaphragm. This is the diaphragm. So almost we can say this is an inspiratory film. On posterior X-ray, the posterior ribs, this 1, 2, 3, 4, 5, 6, 7, 10, and 12, almost 12 are visible on lung fields. So this is almost inspiratory field. The other important parameter to know before seeing specific pathologies on chest X-ray is the quality of the X-ray, whether it's over penetrated, under penetrated, or normally penetrated. Usual X-ray, almost the fourth thoracic vertebra, under the fourth thoracic vertebra is visible. Below that, it will not be visible. But in this X-ray, we can even count the lumbar vertebra. So this is highly penetrated, deep, making the lung pathology will obscure and it's not visible. So this is very bad X-ray to interpret lung pathology. So this is still over penetrated because you can see even up to the lumbar vertebra. Usually up to the T4 vertebra, if it's visible, that's good X-ray. So almost this is wide X-ray and this is under or poorly penetrated X-ray and very difficult to interpret. The other important parameter you want to know is whether the X-ray is taken in supine or erect chest X-ray. When you see this X-ray, this is for erect chest X-ray, this is for supine, making the mediastinum so wide. You can't comment on mediastinum on chest X-ray taken on supine position because normally the mediastinum becomes widened and it seems almost the mediastinum is significantly widened up. But usually this X-ray is taken from supine position. So one has to request erect chest X-ray if possible, or always to interpret for chest X-ray for lung pathologies. So the other important parameter we want to look is the side of X-ray. Which one is the right side? Which one is the left side? Usually, as you can see clearly, this is the right because it is labeled. But this is not enough for all physicians. This labeling may be mistaken, or sometimes the labeling may be not be there. So because of this reason, one should have to look for anatomies, which are very important to identify the right, which one is the right, which one is the left side. So the first thing you will look is the aortic knuckles. This is usually in left side of the chest. So the aortic knuckles is found on the left side. When you see the total cardiac load, almost it is on the left side. So when you see this cardiac load is so more of this side, so this is on left side. The other important is the position of the diaphragm. The position of the diaphragm because of the lever below the right costal, the right hemidiaphragm, so it will pull up. So the higher the diaphragm on the right side is usually higher than the left one. So this is the right up when you compare with this one. The fourth one is the gastric air shadow. This is the diaphragm outline. This dark material seen here is the air in the gastric shadow. So presence of air gastric shadow below left diaphragm is the presence, the indication this side is on left side. The other, when we closely see the lung, the right, because of anatomy of the right and left bronchus is wider, straight and short, and the right lung has 3 lobes, but the left is 2 lobes. And the third reason is the left hemithorax is additionally occupied by the cardiac. So when you closely compare, because of these 3 reasons, one is the right bronchus, the other is the lung segment, the lung lobes, and the third one is because of the cardiac will occupy the part to share part of the left hemithorax. So because of this reason, usually the right lung is greater than the left lung. So when you compare the 2 lungs, here the right is more wider than the left one. This is not always visible to our eyes. So Using these 5 parameters, the aortic navel, the cardiac shadow is more on the left side, the right diaphragm is higher up, the presence of air gastric shadow, and the volume of the lung. One can say this is the right, this is the left. So still when you compare here, this is the right, this is the left, because the diaphragm is higher up on the right side, the left cardiac border is here. You can see also air gastric shadow, same is here. So if you see the X-ray we see here, this is liver totally opaque. This is the right diaphragm. This is the left diaphragm. So there is no any gas below right diaphragm under normal circumstances. But when we see here, this white line is the right hemi diaphragm. This white line is the left hemi diaphragm. There is gas below both diaphragm. This is also gas. This is gas. So this is very pathologic. So there is air under diaphragm. Presence of air under diaphragm. So the presence of air under diaphragm, there are a lot of differentials. Students are expected to read on differential diagnosis of air under diaphragm. Most of them are GI perforation, like duodenal perforation and ITC, and the post-operative and others as well. Read on that. The next important pathology is pneumothorax. Pneumothorax is simply a misnomer where airs are found in the pleural cavity, not in the other part of the thoracic cavity, where air is found in the air pleural cavity. So when we see here this X-ray, so this is the border of right lung. So below this you don't see any pleural vasculature like this one, white line, pulmonary vasculature. So this is significant air in the thorax, called pneumothorax. Diagrammatically, this is a full lung, white, slightly red thing. This is very collapsed lung with full of pleural space, occupying pathology. It could be, this is diagrammatic presentation. It could be air or it could be fluid. So still here we can see the bronchovascular markings are seen up to the end of the lung, but when we come to here, you don't see any pleural bronchovascular marking beyond this line. Medial to this, we can see a lot of white dots. These are bronchovascular marking. This is pneumothorax. When we see CT, it is what we mean bronchovascular marking are this white material, this cross-sectionally cut section of the CT scan. These are the lungs. These are lung border. Beyond this, you don't see any white material, which is pulmonary vessels. So you don't see here. So this is pneumothorax. So still, you will see there are a lot of pulmonary vasculature seen up to the end of this side, but on this side, beyond this line, you don't see any pulmonary vasculature side. So this is completely dark air occupying lesion. So this is a massive pleural effusion with some shift towards the midline. So this is diagrammatic presentation of the same picture. So this is air totally collapsed the contralateral lung and pushing the mesentery to the opposite side. So this is tension pneumothorax. The other important pathology here we see is subcutaneous and the mediastinal airs. So airs in the pleural cavities in the chest is pathology when it occurs in one is in the mediastinum. So these are some of the airs you see in the mediastinum. Usually you don't see in the normal. So these are the airs you found in the subcutaneous tissue, very massive one. So this is what we call it air in the mediastinum. And the air in the subcutaneous still expanding to the neck. So these are air in the subcutaneous tissue and the air in the mediastinum are surgical emergencies. So here, pleural cavity, pleural space is a potential space. Air pathology condition, air and fluid may accumulate. Fluid could be blood or pleural effusions or even pus. So these are the lung diagrammatic presentation, completely expanding lung with potential pleural space wide line. So here there are fluid collection, the pleural cavity comprising the line. So this is what we call meniscal sign because of surface tension or inverted T-shapes. Inverted T-shape sign. So here is a normal lung on both sides and the lung is completely expanding, no pleural collection. So here is a normal chest X-ray. In normal chest X-ray we have costophrenic angle and the cardiophrenic angle. So the cardiophrenic angle, as you can see, is obtuse angle, and the costophrenic angle is very acute angle here as well. This is costophrenic angle acute, and this is obtuse cardiophrenic angle and costophrenic angle. So here if you see on this side, still this is the diaphragm outline. So the diaphragm outline here is acute angle of costophrenic angle, but if we see here the angle is obliterated. So there is minimum pleural collection in the right side with obliteration of only costophrenic angle. That's the cardiac, the diaphragm outline is clearly visible. Here if you see on both sides the costophrenic angle is obliterated with a slightly meniscal side, so with inverted T-shapes. Same is true here. So there is obliteration of costophrenic angle with meniscal side lateral localization. Here the X-ray is actually cut on this side, the angle is acute, but here we have a massive pleural effusion with meniscal sign, costophrenic angle obliteration. So this is pleural fluid collection. So this is a special type of pleural fluid collection where there is a localization. Under normal condition, fluids are found on the lower part, and the upper part will be the lung as we see in the picture above. But here, because of localization, so the fluid will be there. The other important thing is sometimes there are lesions which are found in the lung or in the mediastinum, so X-rays are also very important for this. If you see here, there are shift of trachea on the left side with this mass in the mediastinum, so it pushes the trachea to the opposite side. This is one of the masses in the mediastinum. So, diagnosis of this X-ray, student may look to this X-ray and diagnose. So this is simply significant collapsed lung. This is a lung border with no air bronchovascular marking. You see here to the end you can see, but here you don't see from above these lines, out of this line. So this is massive pleural collection on the left side with collapsed lung to the high lung. What you can say about this X-ray? Still the same. If you gently look, there are lines here on which you don't see these white lines. So this is pneumothorax. The other important surgical pathology of the chest is rib fracture. One should have to look also for the bones. So if you can see here, there are fractures of the ribs. Actually, this is very penetrated, and the fracture of the rib, if you don't look specifically, gently, you may miss specifically on the lateral side. So nowadays, in a computer there are magnifiers. One should have to use that to diagnose rib fractures. So these are very significant rib fracture in two sides, what you call it usually 3 or more ribs above two sides fracture. This is called filial chest. The other important thing when you look at chest X-ray as grosses, you should, nature is wise. Usually we have two lung, so one should have to compare before looking into detail. One should have to compare the right and left lung. As we said before, right lungs are usually slightly larger than the left lung. So you should compare this if there is sometimes sometimes you may not see the pathology, but there are significant volume loss. If you see this lung, this is on left side because of aortic nasals, cardiac load, right diaphragm side up, left diaphragm is lower down, or because of this is the left side, this is the right side. So when we compare the two lungs, the right lung is significantly compromised or collapsed in volume. There is volume loss. So here we have a significant lung fibrosis. This lung fibrosis may not be clearly visible, but if you take to the volume, so you can easily guess what is going on in the right lung. And you may also suggest other investigation to see detailed pathology like CT scan of the chest. What is the diagnosis of this chest X-ray? Still pneumothorax. You can see here there is a line, which is the visceral pleural line, or simply the lung border. Beyond this line, you don't see these pulmonary vasculatures. So this is pneumothorax. So this is all about. This is just to give you a highlight or basic on chest X-ray reading for medical student. So thank you, and read more to get more